And now patient advocate Teresa Reagan will introduce our speaker. Teresa?
Thank you, Past President Joe, and good afternoon, everyone. It's my pleasure to introduce our fellow Rotarian and speaker, Kirsten Johnson. As the Commissioner of Health, Kirsten has overall responsibility for public health assessment, policy development, and quality control activities associated with the preservation of public health for the city of Milwaukee. Kirsten has spent the last decade working in public health and health policy, first as a fellow and then as a local health commissioner. In 2010, she accepted a role leading the Washington Ozaki Public Health Department, where she remained until she took the helm of the Milwaukee Health Department last year. During her time at Washington Ozaki, she also held a 2-year fellowship with the Robert Wood Johnson Foundation Health Policy Program and served as the health policy advisor for Representative Ron Kind in the U.S. House of Representatives. She then went on to lead the pandemic response in Washington Ozaki and then, of course, in Milwaukee. Kirsten first became interested in public health while serving as a Peace Corps volunteer in Mali, West Africa. Upon her return to the U.S. in 2001, Kirsten received her Master of Public Health degree from Tulane University's School of Public Health and Tropical Medicine. She and her husband, Dan, live with their 3 children on Milwaukee's East Side. Looking to the future while working on the challenges of today, Kirsten will speak about Milwaukee's Public Health 3.0 plan and the Milwaukee Health Department's many priorities. Please join me in welcoming Commissioner of Health Johnson as our speaker today.
Good afternoon. Thank you. So, how I got started in public health. I think public health, lots of people, I personally didn't know what it was until I was living in West Africa in a village thousands of miles away from my family and also hundreds of miles away from any other Americans, where I worked really closely with women and children. I was tasked to do health education and a maternity at a maternity ward. And what I really ended up doing was a literacy project for women. Most women in Mali only go to school till the 3rd grade. I did family planning. I did some really amazing artistic paintings on walls. I ran a radio show that really served as, I think, entertainment for the village on a weekly basis. But what I really did was bridge and build relationships with women in the community and talk to them about their lives and how connected the way they lived their lives was connected to health. And for many of them, they had very poor health outcomes. When I returned to the United States is when I realized I wanted to study public health and went to graduate school at Tulane. And initially wanted to go back to Mali, go back to West Africa, and serve the same communities I started in, but realized that in the United States, we also experienced those same significant poor health outcomes, and that I'd be able to better serve my community by staying here. So I've held a number of leadership positions throughout my career. I started in New Orleans working at a nonprofit with Latina and African-American women, worked briefly for Aurora before they were Advocate Aurora, ran the Healthy Wisconsin Leadership Institute, which worked with local health departments on how to do public health. What is data? What is epidemiology? How do you translate that into practice? And from there, I went to Ozaki, was the health officer in Ozaki County, merged the Washington and Ozaki County Health Departments, was a Robert Wood Johnson Foundation Health Policy Fellow, and then here I am in Milwaukee, right in the middle of a pandemic. Do not recommend. So why this role? Again, I started in public health because I'm very passionate about people and humanity. I wanted to leave the world a better place, and it really aligns with my core values, that I really was up for a change and for a challenge. Knowing the significant health disparities we experience here in Milwaukee, it was important to me to get back to the community I lived in. So it aligns with my passion. I'm also an experiential learner, and I joke that for 2.5 years I did not get COVID, and then when I did, I really got COVID. So I tested positive for 12 days just to make sure that I could, hold on to it for as long as possible. But the work that I do now really, and what I value most in my team is authenticity and integrity. and that we have an opportunity in the city of Milwaukee to be creative about how we solve the problems we're facing with health disparities. So I'm going to give a little brief overview about what is public health and governmental public health in Wisconsin. So we are tasked by, there's federal guidance to implement these 10 essential public health services. Essentially what they are is to assess the communities we work in for their health data, identify policies or implementation programs to address what we see in the data, and then assure that people have access to care and have access to a healthy life and healthy outcomes. There's also these foundational services. Again, there's lots of organizations. Lots of organizations that, at a federal level, that put together what it is that public health should be doing. And I want to point out in both of these last two slides that it doesn't say clinical services. And historically, in the city of Milwaukee, we focus on clinical services in the health department. Again, there's statutes in the state of Wisconsin that really outline what are required to do. I'm not going to read this to you. They're very long and lengthy, but they also require us to really look at the data in our communities and identify how we can address health. So, Public Health 3.0, what it really is so historically public health late 1800s, pre-1900s was what drives health? And we knew that, for example, dirty water made people sick. So really sort of rudimentary, we knew that if we cleaned up the water source, people would be healthier. You think about and actually I'm going to go back to that, and it was in Milwaukee specifically, one of the big issues that the city of Milwaukee Health Department dealt with was contaminated milk. So cows that were in the city and cows that were outside the city had the milk coming from those different dairies was different. So the city of Milwaukee Health Department had a pretty critical role in ensuring access to clean milk, clean water, and sanitary systems. So then we moved into the early 1900s, and then mid 1900s. Suddenly we have vaccine. We understand that disease drives illness, and now we know how to treat it. So thinking back to sort of historically, what did health departments do? The immunizations, inoculations. We actually have in the city of Milwaukee, one of our clinics was a former TB hospital. So we treated TB patients. So health departments were really operating in that clinical space. We've now realized that what drives health isn't necessarily the access to care or getting the actual care. We know that only 20% of people's health is related to actually going to the doctor. What we know drives health now is those root causes of health. So the social determinants, so things like access to housing, economic opportunity, educational attainment. And health departments in roughly 2015, this idea of Public Health 3.0 was coined by the federal government. The idea is that we as health departments, we have a lot of expertise. We have epidemiologists, we have biostatisticians, we have access to lots of data. How do we use the expertise and resources we have to think critically and be thought leaders in this sort of how do we address those health disparities? So the movement that we're now working on in the health department, so certainly we've been responding to the pandemic. We're now responding to monkeypox. We're also thinking about polio. But how do we really address health in the city of Milwaukee? And it's not going to be through immunization campaigns, which are certainly important, but we really need to fundamentally address why people are unhealthy. And they are unhealthy because we have poverty, we have lack of educational attainment, we have lack of economic opportunity, we have lack of transportation, all of the pieces that all of us in this room have access to, and many people in the city of Milwaukee do not. So again, the social determinants of health, that's really where we're trying to focus our efforts in the city of Milwaukee Health Department, thinking about access to care, the neighborhood and built environment, so social and community context of that connectivity, which we saw was so critically important during the pandemic, the economic stability, and again, educational quality of and access to good education. Which leads me to our strategic plan. So we just finalized our strategic plan for the City of Milwaukee Health Department, which is the first strategic plan that's been written in the last 10 years. I tasked my team to come up with a 5-year plan that can address the health of Milwaukee and also using an anti-racist framework. Some of you may be familiar that in 2019, the City of Milwaukee and the county declared racism as a public health crisis, which I absolutely believe. But the next step was, okay, how do we do that and what does that mean? So we've really been thinking hard internally about what that means. Here's a picture of our strategic plan. It's going to be on our website this week. So how did we get here? We used data and brought in teams and people from all over the city to talk about what is public health, what are our priorities, and what is an anti-racist framework. We engage staff at all levels, from our admin assistants and lab techs to our medical assistants, all the way up to my deputy directors and my PhD trained epidemiologists, and then made sure that we got feedback from our community partners and residents. And what we came up with are overarching strategic goals. Trying to provide an overarching vision for the department, and it isn't specific to any one branch in the department. So historically, again, the City of Milwaukee Health Department has been pretty siloed. So we have emergency preparedness, they respond to COVID. We have disease investigators, they respond to STI. I have my WIC team, they work on women, infant, and children, which is a supplemental nutrition program. That's what they focus on. We have a dad's project, they focus on fatherhood. And what we're really trying to do is have the entire team understand that they play a critical role in addressing those social determinants, and that collectively our work is really important. And again, it was going to take all of us to get there. When we started asking questions within the teams, we realized over the past 2.5 years, as many of you have experienced as well, the trauma that everyone's faced. So staff and the City of Milwaukee Health Department have faced their trauma themselves going through the pandemic and managing their lives and their families. Many people have experienced death and severe illness, long COVID, and within their families and their friends. So there's trauma personally, but then also the trauma of serving in the health department over the last 2.5 years. The City of Milwaukee Health Department has been under a lot of scrutiny. I'm the 5th commissioner in as many years, in 5 years. So there's been a lot of change. And then on top of it, really being tasked to respond to the pandemic. So early on, we were doing the contact tracing, identifying every single case of COVID, calling them and trying to stop the spread. And then moving towards mass vaccination. Again, we had a very significant role, and we were all on call all day, all week, all year for what we thought was going to be a short period of time, and ended up we're now at 2.5 years. So there's a significant burden on my staff of just having managed COVID, and then also the personal stress. So what we realized is that we really need to focus over the next 1 to 3 years internally before we can be real advocates for any sort of anti-racist work, any sort of work at Public Health 3.0. We need to work on our own culture within the department. We need to work on our management structure, really focusing on our people and bringing them up. And then looking at the strategy. So how do we do that Public Health 3.0 effectively? And for each of these, there are specific tactics and goals. And then once we get through the first 3 years of really recovery for all of us, it's our opportunity to then be outward facing, partnering with all organizations, which we've done a tremendous amount of work of already. We'll continue those partnerships that we have existing, but being thoughtful about how do we leverage relationships with organizations like yours and businesses like yours to address some of these real significant challenges like economic opportunity and educational attainment. And we really envision ourselves as the chief health strategist for the City of Milwaukee, as a driver of policy, as an advocate, and a true partner within the city. So again, here's this anti-racism approach across the 3: culture, management, people, and strategy. And again, one of the things we talked about internally is how do we address racism in the City of Milwaukee? For example, redlining, which we know has caused some of the housing challenges we experience. How do we dismantle these systems when we internally are operating within a system as well that's been built? It's a government system. It's been built on a hierarchy. How do we do that? So again, really focusing internally on our own policies and procedures. So, and as an example, we made this declaration, racism is a public health crisis. Within my first week at the department, we were setting up mass vaccination sites at the Wisconsin Center, and we had created inadvertently a barrier to people getting vaccinated because we're asking for Social Security numbers. And for me, when I found that out, I was like, absolutely not, we cannot. And as it turns out, there had been a conversation before I had even started that we had to, because that's just what we had always done. And so again, it's breaking through some of these ideas that, yes, we are providing health care, we're providing vaccines, but we don't need Social Security numbers. We are not doing anything with that information. Just because we've always done it doesn't mean we should continue to do it. So again, looking at how racism influences our programs, who and what, our data, who we hire, and how we really support our staff. And then core to Public Health 3.0, like I mentioned, having those authentic relationships with our partners. How do we divest some of the power that we hold within a government agency? The City of Milwaukee Health Department has 140 active grants in addition to our levy dollars that come in, so it's close to a $50 million budget total. How do we assure that the money that we're taking in is really getting to the community and to our partners who need it the most, and who frankly should be the ones doing the work on the ground? So, which brings me to doing the work on the ground. All of that has been it's taken us a year to get there with our strategic plan, because it's just all of our time has really been spent on continuing to respond to COVID. Like Dr. Gleason mentioned, monkeypox, we currently, knock on wood, have not had any monkeypox cases in the month of September in Milwaukee. And now really we're faced with polio. And I've been asking my EPI team to pull data and numbers. And frankly, I know polio is something that's really important to Rotary. When I was a Peace Corps volunteer 25 years ago, I worked in a polio eradication effort in Mali and literally brought vaccine to people's houses. And I never thought that I'd be standing in front of a group of people 25 years later talking about polio in the city in Wisconsin, in the United States. But we have vaccination rate of polio at 70%, just over 70% in the city of Milwaukee. We have pockets in the city that are under 40% vaccinated. So we've been working really closely with our school partners, our private and public schools to encourage more children to get vaccinated. But this issue of people being concerned about this sort of anti-vax effort is going to get us. That we are going to end up with children who are hospitalized with polio, which is a preventable disease and can cause significant disability and death. And I'm very nervous. I mean, we see what's happening in New York. It's only a matter of time before we have it here. And again, we have pockets of our population that are really under-vaccinated, significantly under-vaccinated. So that's what my team's working on now, trying to think about how do we prevent that, really trying to increase our vaccination rates. We're working with our healthcare partners. The Milwaukee Healthcare Partnership's been a tremendous ally and advocate for us. But similarly, in your workspaces, if you work with families or if you work with children in any way, please encourage people to get them caught up on their childhood vaccinations. We really are faced with some, I'm fearful of what this can mean for us. With that, questions?
Thank you very much, Kirsten. I'll bet in this room we're running a 98% polio vaccine rate because we were all vaccinated in the 50s. Does that vaccine still provide us protection?
That's a good question. Actually, I'm going to turn it back to you, Dr. Gleason. My understanding is that it does. Yes, my understanding is that it does. But polio vaccine is usually given to children at birth, so at 2 months, 6 months, and then all the way up to age 6. It's a 4-part series, and we know children oftentimes are caught up in some time up until 2, but then when they get enrolled to school, they should be all the way caught up. But again, over the past 2 years, I think we're also at more risk because kids just haven't been going to the doctor because of the pandemic. So we have a gap of kids who have not seen their primary care providers and are not caught up on their vaccine.
I have the advantage of having heard you speak at Tempo last week, and I was just gobsmacked, and I shouldn't have been, by the statistics you cited on the direct relationship between lead poisoning and
Violence.
Violence. Could you talk some about that and really expand on that in terms of, you know, there's one thing with the statistics, and then there's the other of, you know, how that plays out and what we see every day and what we can do about it and what kind of role there might be.
Absolutely, thank you. So I didn't talk about our lead program. Over the past, since I started really in the last 18 months, my first task that I was most concerned about was our lead program. Again, some of you I'm sure are familiar with the news. We have really turned our lead program around, and there's been a significant investment by the city into our lead program to the tune of $26 million. So every time a child is lead poisoned, the City of Milwaukee Health Department gets that information. We reach out to the family. We do the case management with a nurse. We connect with them with a provider if they don't have one. And then we also go into their homes and remediate any risk of lead exposure. So the lead poisoning we see in Milwaukee is directly tied to lead paint. I know there's lots of conversation about lead in the water. No lead is a safe exposure to lead. However, what drives lead poisoning in the city of Milwaukee is lead paint. On average, it takes us $25,000 to remediate a home. And oftentimes people move, so they may move in the middle of a renovation, and we have to then remediate the home they go to next. We do have a significant number of children poisoned every year in the city of Milwaukee, close to 2,000. For the last year and a half, the Magellan lead testing system was contaminated. So for the last year, no children have been tested for lead. So we're anticipating a significant spike in the number of children who are identified as lead poisoned, and then subsequently the work that we're going to have to do. To that point of divesting wealth, we've really done a tremendous job of partnering with community organizations to help us in this work. So help with the remediation work. It takes we have to get a contracting team out there. It can take months to clean up windows, outdoor paint. There's a lot of exposures. But what I think is most critical and what most people don't realize why lead poisoning is important is it actually affects children's IQ and can be directly connected to behavioral issues, including violence in long-term as adults, perpetuating violence or being victims of violence. So in the city of Milwaukee, it's upwards of 50% of people who are in our county jail were lead exposed as children. If you Google it, you can find all kinds of data of lead poisoning being related to violence. If you look at cities with the highest rates of violence, they also have the highest rates of lead poisoning in children. So there is a connection, and it's so critically important that we invest in our children and preventing this from happening.
Well, thank you for your remarks. Several weeks ago, we heard about the plans from Make-A-Wish Foundation for Milwaukee Academy of Sciences. It was billed as kind of an education program, which I'm curious as to whether you see any public health components or wraparound services for the households, for the parents, et cetera, health, family, household, housing, et cetera. I'm not sure if you're familiar with that proposal, but I'd be curious as to whether you see any possibilities of a total family, a total household approach, all aspects, with transportation you talked about, housing, health, nutrition, et cetera, as well as employment.
I'm not familiar with that application specifically, but I do think there is value in wrapping our services around these families in their entirety. And for lead, for example, we play a significant role around lead and lead paint, but making sure that the homes they're living in are lead paint free certainly is a role that we can play. And again, we also know that many families have significant needs, and how do we assure that those services are being provided sort of in a one-stop shop? When we're asking families to get to a doctor's appointment and then come to the health department and then go to housing and then go to WIC, it is incredibly challenging even for those of us who have resources, but I think we need to be more thoughtful about how we make it easier.
You might check with Milwaukee Academy of Sciences and City on the Hill, which is adjacent to that approach.
Thank you.
Hi, Kirsten. Brent Afwassen. How do you, in the midst of continued EUAs coming out and now maybe monkeypox, polio concern, your discussion today isn't about like the crisis of the immediate. I mean, lead is a 100-year-old issue. Right. Racism is more than 100 years old. How do you shift your resources so that it's not always responding to the new crisis of the moment because these are issues that are grounded really deeply and it'll take a committed, sustained effort, and it doesn't handle the 6 o'clock news headline. Well,
right. That's a good question. And it has been challenging to be strategic and think in terms of what is our role now and in the future versus how do we deal with the crisis of the day, which is currently monkeypox or COVID or whatever it happens to be, an outbreak somewhere. So and Myra, my chief of staff, can speak to this. We've literally carved out time in calendars of leaders in the department to say this is our hour and a half every week where we're going to sit down and talk about the strategy moving forward. But we also have time every week at 7:30 on Thursday mornings where the team sits down and talks about the crisis of the week and what is happening. And that used to be every day, so we've scaled it down to one time a week. But we used to meet every morning at between 7 and 7:30 to talk about what was going on. But it's been very challenging. I think the piece that's encouraging is the federal government has recognized the need for all health departments to rebuild our infrastructure. So a lot of money coming into the department is specific to that sort of public health 3.0, the epidemiologists, the data scientists, and those strategists. So those are the teams that we're trying to invest in because those are the sort of the thought leaders thinking on, the creative thinkers about how do we invest our time and our money long term to address those root causes. Yeah.
Just a quick question, Kirsten. I'm curious because you're the Commissioner of Health for the City of Milwaukee, and of course you were in a North Shore, a couple of counties. How do you work with the other commissioners in the area?
It's a good question. And many of them are new, so it's been challenging. So over the course of the pandemic, the state of Wisconsin's lost over 50% of the health officials. So we have a real issue with longevity and stability and building a foundation. But we meet weekly. We meet weekly as a county. So there are 11 municipal departments in Milwaukee County, which is unique to Milwaukee. Most other, all of them except for Appleton have our county health departments. But we do work really closely together. And it's interesting because each of those municipalities has their own politics and their own priorities. But we do meet weekly to try to be aligned in how we sort of, well, it started through the pandemic, but now also as we move out, sort of thinking about infrastructure, we're trying to work together. Yeah.
Thank you. I've really enjoyed this program. I would imagine public health has always had an image problem and a criticism problem, but to my mind, it was brought to a head with the politicalization of the vaccination issue. Does your department have an action program to deal with that issue now? And if so, what is it?
That's a good question. We talk a lot about the politics, and I think I always say, like, people didn't get into public health because they wanted to wade into politics and become polarizing. Every single person who's in my department is because their values are there, because they care about people. I think one of the things that served us well now in the city is that the team that's made up, my leadership team, has a deep understanding of politics and their influence. It's interesting too, because at the federal level, public health's not done ourselves any favors in terms of communication strategy in the last 2 years. I think we can all admit there have been some failures. There have been some great successes, but it's been challenging. I think we have to acknowledge that there is no sort of public health litmus test. I think where we get in trouble is when we're black and white. During the pandemic, every decision we made was a bad decision, and it had to be made. You had to make the best decision with the information you had, recognizing that it was going to have an impact on people one way or the other. Either their health was going to be in jeopardy, the economy was in jeopardy, kids were missing out on school, so the educational attainment piece. So every decision we made was not good. And I think we need to admit that. I think it's sort of a reckoning, and we're still grappling with that in the public health field. I mean, it's been really difficult, but it is part of our narrative every day in our conversations at work, is how do we balance the politics with what is right and assure that, and also thinking about the economy and education. And it's a dance for sure. It's been challenging. Yeah.
How accurate are the health statistics that we read, especially around COVID, where we're self-reporting and people are embarrassed to say they have it or don't have it and are spreading it further? And have we learned anything or changed any practices with regard to health and hygiene and things like that as a result of the long period of COVID that we've all gone through? And again, today, if we look around the room, we're not wearing masks. We're not, right. But we all go to places where we are required to. And, is there going to be a norm in the future?
That's a great question. So I think our data now, we have to look at the trends. So the data point of the burden of the number of cases per 100,000 in the city of Milwaukee is wildly inaccurate. What we look at now is how is it going up or is it going down? And we've also learned there's other data points to look at. So wastewater, for example, we've been relying a lot on wastewater, and we're looking at how do we measure polio in our wastewater, monkeypox, and other things too. So this is sort of a new opportunity for the city of Milwaukee Health Department. It's exciting because that's the direction we're trying to think in. I think we got into trouble during the pandemic when not just the city of Milwaukee, but across the country, we kind of came up with our own metrics, and then we aligned them with sort of openings and closures, and because everybody wanted an answer, everybody wanted it to be clean and simple, and the reality is it was very gray. So it depended, like the setting where you were in had different levels of risk, and nobody really wanted to talk about risk because it's not clean and easy and like, okay, at 100 cases per 100,000, we're doing X. So I think we have learned a lot about you have to be able to speak to those gray areas, and you have to understand risk, and we need to talk about some of this information differently. But currently, the way we look at our data is very much as trends. The other piece that's being taken into consideration around COVID is, and particularly MPS, is hospitalization data. So we're early on, this is one of the fractured infrastructure of public health. Our data collection systems are different across the country, and they don't talk to each other. So early on, we couldn't get hospitalization data. So for example, in Washington, Nozaki, we have Aurora, We have Freighter, but we have 2 hospitals. One of our hospitals was Aurora's COVID wing. So we had patients from from Milwaukee there. So if you looked at the hospitalization data for Ozaki County, it was incredibly high, but the reality was it didn't reflect the residents who were from Ozaki County. Similarly, in Milwaukee, we get all of the most acute COVID cases come to Milwaukee out of the whole state. So our hospitalization data fluctuates, but again, it is not necessarily reflective of the community we're in. So we look much more closely at those trends. That said, the hospitalization data, I think, is really the direction we need to look for COVID because it's most accurate in terms of severity of disease and potential for death because those people are hospitalized. Yeah.
Could you describe how the City of Milwaukee's Health Department addresses the mental health needs of the community?
Sure. So the City of Milwaukee Health Department has a small slice of the mental health piece. It is something that we have a strategist now assigned to. We collect a lot of data around mental health, so healthy, self-reported good mental health days. We collect that data and share it. The county really has the lion's share of the mental health work. That said, with substance use disorder and the opioid money coming in through the lawsuits, the City of Milwaukee is getting money for that. We're working more closely with the fire department on, they have a rapid response team for overdoses. But we're also trying to think creatively about how do we serve as the convener, again, that Public Health 3.0. How do we serve in the space of being the data collector and connecting that data to the providers? Is it a role for us to be sort of a clearinghouse for access to care, for mental health care, which is a huge challenge in Milwaukee? But again, trying to really be thoughtful about what our role is, because we are not mental health service providers, but we can serve in a role of convener and sort of data collector. Yeah. Thank you.